Hello?
Hi, Chris, you hear me?
Yes.
Oh, okay, great. All right, I'm gonna make you the host.
Okay, hold on 1 second.
Okay.
Yes, okay.
Okay, want me to make you host?
Yes, please.
Okay, hold on. There you are. Okay. FYI, I don't know if you know, but we actually do have a microphone and speakers here now, so they can hear you.
Okay, I just wanted to. Oh, you didn't let people in the waiting room? I mean, they're in the waiting room.
Since you're the host now you'll need to admit them. You can admit all. You know how to do that, right?
Yeah.
Yeah, just admit all.
All right, and all I want to do now is get them to.
And they'll still be, probably still some will be logging in over the next minute or two. So.
And well, don't go away because I want to share the screen.
Yeah, I won't.
So cold. Oof.
It's warm here.
Is it? Yeah.
If you can hear okay and you can see okay, you really don't need to log in through your device. Okay, so it's really up to you. You're probably going to get a reverb if you log in and listen, so that's up to you.
And I need to share the screen.
You can hear okay? Yeah. Okay. Because I don't know if I can adjust the volume on this. Let's see. And it is recording, so.
Okay. We could edit this part, right?
No, what, you fixing your hair?
No. We could edit this part because it's not.
Actually, no, once it's recording. So I'd have to stop it. I'd have to stop and start if you didn't, if you wanted to wait.
It doesn't. I'm just looking to share the screen. Oh.
Actually, now you're the host, so you would have to stop and start recording.
I have to keep admitting people because they're not all here. All right. Come on, guys.
Including you, there should be 25.
Stop coming in one at a time. I only have 16.
You should be able to admit all if there's more than one waiting.
I did.
Oh, okay, well, they're still straggling in. These students, they never log in when they're supposed to.
I'm here. I'm in there.
No, you're right.
www.noshot.com.
Hey, Chris, while you're setting up, I just want to yell at them for a minute.
Sure, go ahead.
No, I'm not going to yell at you. I'm just going to remind you, please make sure, if you have not done so already, get your Castle branch information in order, okay? And one of the other things that's on there now that's new.
Oh, the COVID.
COVID, right. If you're able to demonstrate that you have received 1, 2 of the COVID vaccinations, you can upload that. If you have not, you're just going to say no. Okay, so you do have to answer it. Okay.
For the meningitis one that you sent us.
And that's not, remember, that's not for us. That's for the state, actually.
Okay. Is there a time frame that we have to get that done?
You'll have to talk to enrollment services. The message you got, I think, was from Sonia Rios Cardosa.
Yeah, we got an email from them.
Yeah, I mean, that's who you're going to need to talk to about it, because that's not our requirement. Okay, so I really can't help you with that, unfortunately.
One other question.
Yes.
FSB PT. We have to create a profile for that?
Yeah. FYI about FSB PT. ASAP. No, I'm kidding. what you get entered into a database now that you're enrolled in the program, so that when you graduate, which you will all graduate, and you're ready to take your licensing exam, we have to validate your graduation with FSBPT. That's the organization that administers the licensing exam that you'll have to take. Okay, so you should have gotten an email that says validate your enrollment or complete your information or update your profile. Basically, all they're looking for is your date of birth, because there may be multiple Marissa Singhs around the country that will be taking the exam. So they need to identify you by your date of birth and your first and last name. And it's your Essex email that identifies you through the program. Okay, that's not an urgent thing for you to do, but you will need to do it before we can validate your graduation. Not for another year. Okay. All right. Okay, Chris, it's all yours.
Okay, thank you. Is everybody here? There's only 18 people here.
My thing is just, it's like loading and loading.
Hold on.
Let us-
So not everyone's here. Where's everyone?
It looks like they're getting slowly.
Oh, that was terrible.
Some people aren't logging in because they can see you on the big screen. So everybody's here, but not everyone's logged in through their individual computers.
Say that again.
So everyone's here, but because she's seeing 18 participants, it's only because everyone's not individually.
Oh, okay. You know what it is, Chris. That's right. Not everyone is logging in because they're watching it on the screen and listening in the lecture hall. So let me get a quick head count here. You're not good at it. 1, 2,
So can everyone see the screen?
Yep.
Yes,
So you see it says Payne.
yes.
Yeah.
Okay, I only see 20. Dave just went to the bathroom. Okay, so Dave just went to the bathroom. It's 21.
We're missing two. Melissa.
Melissa is remote,
Yes, and Stephen.
and Stephen is remote. Okay, so Dave is just ran to the restroom. He'll be right back, and then everybody's here.
Okay, because so I don't have to admit anyone anymore.
You should not, no.
Okay.
Nice catch. Thank
But I only have 20 participants.
you. Yeah, because again, some people are just watching in a lecture hall.
Okay. All right. So I will start. First of all, let me say that everyone got their email regarding Friday, right?
Yeah.
Yes,
Ashka, you understand it? Yes?
yes.
Okay, so the first group and the second group, what we felt might be more beneficial is to go up and to look at lines and to actually practice some things that you might be doing in clinic, like transferring to someone when they actually have an IV line, or and listening or auscultating to blood pressure on these mannequins that well, we know what the reading is, so we can identify whether it is you're doing it correctly or not. And then all the lines, Professor Scott will be able to show you the types of catheters and how they're used. And there'll probably be some stations that you'll be going to and be not really tested off, but just doing different things at specific stations. It's the only time we could really get you in. And I think it's more beneficial than doing a soap notes. I mean, even though they're important to do, it's something that you just have to do in order to understand how to do it. We're going to talk about pain. Oh, the other thing I wanted to say is that you will have an exam next Wednesday. There's no school on Monday because it's President's Day. So you will have an exam on Wednesday. The exam will be on Moodle. Okay, so it'll be on everything that we covered except for today. The information we have on today that we're providing today is not on next week's exam. And we're figuring out how we might want to do a practical with that and I will keep you updated. But for now, it'll be a 50 question, multiple choice, and a bonus question. So on everything that we've done to this point. And when we talk about body movements, of course, one of the things we're going to talk about today is pain and the mechanisms of pain and how pain, the theories of pain and how pain is perceived. And actually pain is in the brain because that's, everybody's different. Everybody has a different tolerance to pain. Everybody feels pain differently. But one of the things that we have to talk about first are proprioceptors. And does anybody know the difference between proprioception and kinesthesia or heard the words proprioception and kinesthesia before? Casey?
So repeat that?
Have you ever heard the difference between proprioception and kinesthesia, or do you use them interchangeably? Some people do. Are you familiar with those terms, proprioception and kinesthesia?
Not kinesthesia, no.
Andrew? Same. Okay. So proprioception is actually where the body's at, knowing where your body's at in space. So when we talk about proprioception, we talk about the awareness of joint position, as opposed to kinesthesia, which is the body awareness when it's moving. So knowing, so being cognizant of joint movement. So proprioceptors relay information about where our body is in space, and they detect little changes in movement, position, tension, force within the body. Of course, when we move, there are several systems that work together, which the visual, the vestibular system, and the somatosensory system. Somatosensory system really involves these proprioceptors. So they monitor and they adjust the body's position. So if we were going to test proprioception or kinesthesia, one of the ways we might test it in an individual to see if their proprioception is intact is raise a finger and have the patient close their eyes and say, is the finger, show the patient first before you do it. Here, your fingers up, your fingers down, your fingers up, your fingers down, your toes up, your toes down. And then move the finger and ask the patient, where is the finger, up or down? Testing something like kinesthesia, which is more involving that cognizance of the joint through the movement phase, more dynamic than static, you may tell the patient to, you may lift the patient's arm up at its side, maybe abducted to 90 degrees, and say, mimic it with the other side. So you tell the patient to close their eyes and do the same thing with their other side. So these are the different ways that we test proprioception and kinesthesia, and to see if the somatosensory system is intact. There are other things we can do too. There's things called the balance master. I don't know if you guys know about balance master or ever seen one, but Newark Beth, and I think probably Dr. Laws might talk about it a little bit. It tests for proprioception and kinesthesia and visual feedback, as well as the vestibular system with platforms that move while you're on them. So you may need to look at something to target and maintain vision on that target or maintain position on that target while the surface is moving. This is some of the same things that you do with a patient when you think about when you're testing them and you're working on their balance. Now, static balance, you may just have them stand, right? Or take their finger and touch their nose. But you may also then put them on some kind of a foam support, right? To make it a little bit more challenging to do these things. And then think about actually putting on something that's movable and asking them to do the same thing. So you're challenging the somatosensory system. When we talk about a muscle spindle runs parallel to the muscle itself. It's within the muscle. So inside the muscle, there are these sensory organs, and these sensory organs are known as muscle spindles, and as well as Golgi tendons are in the tendon, but muscle spindles are in the muscle itself. So we have these intrafusal and these extrafusal fibers, and we also have information that's taken from these muscle spindles that goes to the spine that connects with an alpha and a gamma motor neuron. The muscle spindle actually attaches to a gamma motor neuron, and the muscle, information from the muscle, the afferents from the muscle go and attach to a motor neuron. So Muscle spindles have intrafusal fibers, and the intrafusal fibers within the muscle spindle are known as the nuclear bag and the chain. And the extrafusal fibers are the fibers all around the muscle, and they do the rest of the work. So when a muscle is stretched, these afferents fire and go to the spinal cord and cause a motor response. The intrafusal muscle, there's two types. The nuclear bags are larger. You could see the nuclear are accumulated centrally, and the nuclear chain are smaller and they're in rows. You don't really have to know this. This is just a little anatomy about what the muscle looks like. So these primary afferents, or these group 1A afferents, they arise from the annual spiral endings from both the nuclear chain and the bag. And they provide information to the spinal cord about how quickly the muscle is stretched, okay? How quickly the muscle is stretched. So it fires in response to a passive stretch, okay? Muscle spindles fire in response to passive stretch. Group 2 sensory afferents, they run around the nuclear chain fibers. They're mid-sized, they're slower, and they inform the brain about how much the muscle was stretched. Okay, so these two sensory fibers come from the muscle spindle, go to the spinal cord, and give information, which ultimately goes to the brain about stretch, about how much it's stretched, and how quickly it's stretched. The gamma motor neurons then, from the muscle spindle, they fire at the same time as the alpha motor neurons. So they're activated at the same time of the alpha motor neurons, which come from the muscle itself. So they're activated, they sensitize the spindle to the changes in the muscle length. So the gamma motor neuron will lead to the intrafusal fibers of the spindle itself. And what they do is they reset the spindle, getting it ready to be able to fire again. So just remember that. The gamma motor neurons are responsible for resetting the muscle spindle. Okay? The alpha motor neuron goes directly to the muscle, and that prevents the muscle from overstretching and tearing. What it does is it facilitates the agonist and the synergist, which means that it lowers the threshold for firing, and it inhibits the antagonist. So facilitates agonist and synergist activity, inhibits antagonistic activity. Therefore, what is good to do in a patient that has low tone or no tone? Something like a quick stretch, because if you do a quick stretch on the muscle, the muscle spindle will fire through something known as reciprocal inhibition, send a signal to the agonist and the synergist to fire, and the antagonist will be inhibited. Okay, so if you want to increase the tone on someone who is hypotonic, let's say somebody who's flaccid, if you provide quick stretches to these muscles, and we'll show you in lab how to do this. I'm hoping that I will be able to come back to lab next week. So we'll show you how to do this. And so anything that will facilitate this muscle spindle will help make the muscle contract. So a quick stretch, tapping, quick icing. That's why when you learned probably a long time ago that when you go down to reach your toes, ballistic movements are not good to do if your hamstrings aren't lengthened, or your low back, or if you have an excessive lordosis and you want to increase the movement in the lumbar muscles. If you do ballistic movements, what's going to happen when you reach down to touch your toes, and well, you know what I mean by ballistic? No? Anybody?
Your strings are going to fire.
Yeah, so if somebody could stand up, I can't see you guys, but if somebody could stand up and reach down and touch their toes and keep reaching and bouncing back and forth, what is that going to do? That's going to stimulate, that's going to actually make the muscle spindle fire which is going to facilitate and stimulate the agonist and the synergist. So it's going to make the extensors of the trunk muscles even tighter. So it is not a good thing to do. So what do we need to do if somebody is hypertonic? What do we need to do if somebody has spasticity?
That have to probably be slow and controlled.
Right. Your slow, steady, controlled stretch. So we don't want to facilitate the muscle spindle and kick in and make that tone increase. We want to decrease it by doing the slow stretch. Okay, so muscle spindle, reciprocal inhibition, facilitates, stimulates the agonist, and the synergist inhibits the antagonist. Okay, this is exactly what
Professor, can you go over the secondary afferent neuron again? What does that do?
the secondary, the primary and secondary afferents, both of them. The primary,
No, just the secondary.
oh, the secondary afferent provides information to the spinal cord about how much the spindle has been stretched. Okay, the type 1 is how quickly it's stretched. So it provides information about how quickly it's stretched, and this is the degree of stretching, how much it's been stretched. That's it. That's all you have to know. Okay. So a patellar reflex is an example of how of a muscle spindle firing, because when you could read all this, but basically without reading all this, what I'll tell you is that when you tap the patella tendon, you guys all did this in class, right? Took a reflex hammer, we tapped the patella tendon. So what happens, and I said the muscle spindle is fired in response to passive stretch, okay? So when we tap the patella tendon, what happens? The quads are passively elongated, right? So this passive stretch will stimulate the muscle spindles. And when it stimulates the muscle spindles, what does it do? So the muscle spindle fires. What does it do? It sends signals to the vastus medialis, the vastus lateralis, the rectus femoris, right? Stimulates it, facilitates it, makes it move, and also inhibits the antagonists, which are the hamstrings. So we get a knee jerk response. Okay, that's how the patellar reflex works. And you could read all this if you want, but basically I'm trying to put it in simple words for you. You tap the patella tendon, the quads are elongated passively so that the muscle spindle is stimulated. This passive stretch, it stimulates because the muscle spindle responds in relation to passive stretch. The spindles will, the spindles fire, and the agonist and the synergist will contract, and the antagonist will be inhibited so that you get knee extension. The Golgi tendon, I can give you guys a good example of this. This whole thing, this is associated with autogenic inhibition. Okay, these are the Golgi tendons are located in the tendons of the muscle, and they are extremely sensitive to active contractions. Okay. So I'll give you an example of this, but they're a millimeter long. They're in the tendon itself. They have 1B afferents, okay, not 1A and 2 afferents. 1B afferents will send signals to the spinal cord, ultimately the central nervous system, on how much tension is in the joint. Both of these, by the way, the Golgi tendon and the muscle spindle, are protective in nature, okay? These are stimulated by an active contraction. And these respond when the muscle is at max load. And remember, active contraction, protective in nature. This will facilitate the antagonist and inhibit the agonist and the synergist. Think about, and this is known as autogenic inhibition. Think about, and I always do this in class, so it's too bad I'm not there because I would do it with Casey because I would win. Arm wrestling. Ha ha ha, Casey, you could laugh now. When you arm wrestle someone, right? You have your elbows on the table, you have your hands, you're pushing, pushing, pushing. All of a sudden, somebody gives out. So the Golgi tendon kicks in and says, okay, let me facilitate that antagonist. So the biceps becomes inhibited, the triceps becomes facilitated, and the arm drops. Okay, so that's an example of when it's protective in nature and a Golgi tendon will kick in. When we do contract, relax, and it's really the name is not really appropriate at this point, but you're going to learn more about that next year. But when you think about the hamstring up in the air and the leg being pushed against you remember when we did hamstring stretching and you put the leg over your shoulder and you said push, 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 push down, relax, and then you took up the slack. Do you remember that? We did that in lab?
Yeah.
Okay. So what do you think that is? Golgi tendon or muscle spindle? So what did we do? We asked for a contraction of the hamstrings and the glutes, right? Then we asked the patient to relax, and then we pushed the patient into more hip flexion. So what's that based on? Activation of Golgi tendon or muscle spindle?
Muscle spindles.
Muscle spindle, you think?
Golgi tendon.
Golgi tendon.
Because we activate, right, it's Golgi tendon. Yes, you were all, I think.
But isn't the contraction of the muscle spindle? And
Well,
then when you actually, sorry, I heard. Sorry, go on.
You're actively contracting the muscle. You're asking the muscle to contract by pushing down, but the Golgi tendon is going to come into play and decrease because, you know, as I said, it's protective in nature and it's an active contraction. This is not passive, right? It's an active contraction. We're asking the muscle to work. So we're asking the muscle to work, and then when the muscle stops working, we can take it into additional motion because now the hip flexors are stimulated. Okay, so this is based on Golgi tendon, this contract relax of the hamstrings. All right, that's autogenic inhibition. All right, now these are all the nerves that you have in your body. This was teased out through, I believe this was one of the pictures that they had in the bodies exhibit.
Yeah.
So what's the largest nerve you have in your body? Sciatic. Sciatic, largest nerve you have in your body, right? Intercostal nerves, ulnar, radial, all those nerves, you guys know. So what is pain? No, pain is activated by noxious stimuli, and nociceptors are peripheral nerve endings that relay information about pain. They're present in almost all types of tissues, and they're activated by any kind of heat, thermal, cold, mechanical, chemical stimuli. And what happens is they release chemicals that increase the response of the nociceptors to painful stimuli. So it's also known as a sensory and emotional experience of discomfort. It's the single most common medical complaint that brings people to the physicians. Pain, right? We all have pain. Qualities of pain, they can be organic versus psychogenic. Anybody know the difference? Organic can refer to something like real tissue damage versus psychogenic. So genic arising from the psyche, right? So people that are depressed, anxious, there's psychological factors that may, as well as their beliefs, their strong emotions, etc., that could keep them in a state of pain. Is someone talking?
It's the
It's the
announcement.
announcement.
Okay, so there's a, everybody hear me? Acute versus chronic versus referred pain.
Hold on, Professor, it's the announcement.
Oh, I see.
What would you say fibromyalgia is? Is that organic or psychogenic?
Fibromyalgia has a component of both.
Okay.
Okay, it's done.
Okay. Fibromyalgia, because it is, they do have real telltale signs of what it is when they look at different things like cerebral spinal fluid, etc. But it also involves the psyche. It has a strong emotional component. Acute versus chronic versus referred. So if I have an MI, myocardial infarction, I have pain in my chest, I can have it in the jaw, the left shoulder, and arm. These are referred pain patterns. So if somebody's suffering from cardiac arrest, this is where they're going to be saying that they have pain. Diaphragm pain is at the tip of both shoulders. Gallbladder pain is referred to the right shoulder and the inferior angle of the scapula. And pay attention to these because you never know when they're going to come in handy. I had a cousin who was telling me that his shoulder was bothering him and he had pain in the tip of his shoulder blade and like the bottom, the mid part of his back. And I said, are you okay? I think maybe you should just go into the ER. He went into the ER. He had stones, gallbladder stones or gallbladder, something he had with the gallbladder. I forget exactly what it was. But, oh, he had to have it removed. That was it. He had to have his gallbladder removed because he was having a gallbladder attack. And the spleen refers to the left shoulder. Okay? This is not, I mean, just keep an open mind. You know, we have referred pain patterns. We also have referred pain patterns with trigger points, right? So there's different trigger points that refer pain throughout the body. Malignant versus benign. We know that malignant is something that it's usually associated or can be associated with metastasis. So malignant tumor is cancerous versus something that's benign. Continuous, it's there all the time versus it comes and goes. Continuous may be associated with something that's highly inflamed, so a high inflammatory process, versus a disc problem, you know, that's not acute, that you've had it for a week or so. And then what do we say? We talked about this on Friday sessions. What makes the pain worse? What makes the pain better? Is it there all the time? Okay, so is it intermittent? Does it come and go? Oh. Oh, sorry. Oh my goodness. All right. So algogenic substances are chemicals that are at the injury site and they can activate nociceptors. Nociceptors are pain-carrying afferents. So they can be activated through histamine, bradykinin, substance P. Substance P is a neurotransmitter that's released and picked up by nociceptors. Nociceptors carry these messages regarding pain. So these are afferent neurons. There are some A delta fibers, C fibers, even A beta fibers will carry some pain, but not so typically. A delta fibers and C fibers are the sensory afferents that transmit information regarding pain. So the peripheral nerve fibers that are involved in that pain reception are A delta fibers. They're small. They're myelinated. So if they're myelinated, they transmit an action potential faster than something that's not myelinated. So it transmits information faster than a C fiber. It transmits information regarding brief, well-localized, well-matched, short duration pain. Okay? Pain can be transmitted by C fibers. They have a slower onset. They're small. They're unmyelinated nerve fibers. They transmit information regarding something that's dull, icky, burning, poorly localized, slower conducting. And finally, A beta fibers are these large myelinated non-nociceptor mechanoreceptor fibers. They're located in the skin, the bones, the joints. Let me give you an example. There can be some mechanical trauma. If you have mechanical trauma, both A and C fibers are activated in response to the chemical mediators of inflammation. So what's going on with the the incident? Think about if you're walking down the street in Manhattan and a brick falls and hits your foot. So what do you think is going to happen? Do you think it's going to hurt? Absolutely, it's going to hurt. So what's going to fire quickly? Those A delta fibers, right? They're small, they're myelinated. They're going to transmit information regarding that brief, well-localized, short, well-matched pain. But then you're going to go home, you're going to look at that foot, it's going to get red, it's going to get swollen, and then what's going to be firing? It's going to get icky. It's going to get, it's going to hurt, it's going to burn. These are more long-lasting. So these are going to be transmitted via the C fibers. So mechanical trauma can activate both and will activate both. But what is firing and when it's firing are the differences. Okay? So this long-lasting pain can also be accompanied by autonomic nervous system responses. So the C fiber firing can also cause people to sweat, have an increased heart rate, have nausea. So all these things, though, can be relieved by some kind of an opiate or opioid. So that's why they administer these kinds of pain medications. So we have A delta fibers, C fibers. These are the peripheral nerve fibers that are involved in pain perception. However, this A beta fiber is thought sometimes it does get involved in pain perception, but not usually. They're large, myelinated, and they're mechanoreceptive fibers. So think about going to a dentist and getting a shot. What does the dentist do before he gives you a shot of Novocaine? When he pulls,
Local anesthetic.
he gives you the local anesthetic, right? Well, before he does that, what does he do? He takes your mouth, he puts his hand inside your mouth, and doesn't he shake your cheek? Doesn't he shake it a little bit before he administers the anesthetic? So basically what's happening is you're getting an override of the A delta and C fibers by the stimulating the mechanoreceptors because they travel a lot quicker. So the A beta fibers are stimulated, which will block, and we haven't talked about this yet, but they'll block the transmission of pain fibers. Okay, so just hold on to that thought for a minute. Okay, so C fibers, slower than A fibers because A fibers are myelinated. So you get an action potential faster. You get a transmission of an action potential because of the effect that you have myelin. All right, so source of pain comes in, C fibers on myelinated, A fibers. Which ones go in here first? There's something in the spinal cord known as the substantia gelatinosa. And then here, this is an imaginary gate, let's say. And we have spinal thalamic tracts that refer messages to the brain, to the thalamus regarding pain and temperature. So if everything is open and this is stimulated, they both go and into the spinal cord. From the spinal cord, substance P is released, which is pain. T cells are transmission cells, and they transmit the information to the brain. That's what happens normally. But there is a theory, gate control theory of pain. Melzek and Wolf's gate theory of pain in 1965. There's factors that open the gate, there's factors that close the gate. And pain is experienced dependent on whether this gate is open or closed. So this severity of pain is determined by the balance of what comes in and what's exciting and what's inhibiting these T cells, these transmission cells in the spinal cord. So T cells will receive either something that's excitatory or inhibitory in that substantia gelatinosa. So if small fibers A delta and C are stimulated, that's an excitatory input to the substantia gelatinosa in the spinal cord, and the gate opens, transmitting information to the thalamus that is sent to the thalamus regarding pain. Okay. Oh. If A beta fibers are this should be down here a little bit. If they're stimulated quicker, they send an inhibitory neuron to the spinal cord, closing the gate and blocking the pain. So depending on what's stimulated, so the A beta fibers will close the gate, the C and the A delta fibers will open the gate. You understand that? So how do we do that? Oh. All right, so we also have ascending fibers from the brain that help control the pain. But there's interneurons in the spinal cord that are T cells, and they send information up to the brain. So there is an imaginary gate. The Melzack and Wall theory says, if the A delta and the C fibers are stimulated, they will open the gate and allow the T cells to open the gate and allow pain to go to the thalamus. If the A beta fibers, the large non-nociceptive mechanoreceptors, are stimulated, they will close the gate. Okay, so there's inhibitory or excitatory input of one or the other. So it's a balance. So think about, what do we do to help a patient with pain? We may provide ice, right? Ice is picked up by those large A beta fibers. Heat. We may do electrical stimulation. So we may tap or stimulate a muscle in some way with a frequency and a pulse duration, which we haven't talked about yet, but we can facilitate the muscle movement. So anything we can do to stimulate those A beta fibers will close the gate. And there's also something known as spray and stretch, which is a thermal, it's a spray can that you spray onto a patient, stimulates the mechanoreceptors, allows the patient to be stretched. We'll talk about that in a few weeks, but the spray is the distraction and the stretch is the action.
Is that the magic spray that they use in sports?
Yes. And it's all based on this theory. Let's stimulate, let's get those A beta fibers to fire so that they close the gate and prevent pain signals from going up to the brain. Okay? That's the theory. So conditions that open the gate, the extent of the injury, inappropriate activity level, anxiety. So pain itself can promote anxiety and confusion, right? Depression. So this can lead into more and more pain. And conditions that close the gate, medication, any kind of a heat, massage. So they're stimulating A beta fibers. If you're relaxed, if you're positive in your emotions, if you're distracted in some way, which is what I said, that spray and stretch get a distraction, and involvement and interest in life activities. I'm sure you've met people like this. They're anxious, they're tense, they're depressed. All they talk about is their pain. And it no longer becomes peripherally modulated, but now it becomes centrally modulated. And when I said pain is in the brain, it is. So now even non-noxious stimuli will cause that person to have pain. Okay. All right. So again, we just said this, the amount of activity in the pain fibers and in other peripheral fibers. So these pain fibers would be the A delta and the C fibers, and these peripheral fibers would be the A beta fibers. The endogenous opiate peptide system, opiopeptins will control pain by binding to specific opiate receptors in the nervous system. So what are they? There are endorphins, there are enkephalins. They inhibit substance P release. Remember I said before that substance P is that neuropeptide that is released when the nociceptors are stimulated. So the pain will be modulated by these endogenous. What does endogenous mean? Endogenous neurotransmitters. We make them. We make them. So we have our endorphins and our enkephalins that we make ourselves. We have endogenous opiates. How do we stimulate these? One of the ways we stimulate this is feeling good. So anytime that they become released is with exercise. That's one of the things. You know, anything that makes you feel good is going to release these endogenous opiates. All right. So they bind to the same receptors as the exogenous, and exogenous means they come from the outside. So what kind of an exogenous opiate do we have? A real common one, morphine, right? So if we apply a painful stim, because we're talking about pain, so if we apply a painful stimulation as acupuncture or TENS are transcutaneous electrical nerve stimulation, we can cause a release of the opiopeptins. So remember, we have a bottom-up approach and we have a top-down approach. So the top-down approach is coming from the brain itself. The bottom-up is coming from stimulation of some mechanoreceptors. Okay. So this is the top-down approach, descending inhibitory system from the brain to the spinal cord, and then which will close the gate. And then remember, we talked about those mechanoreceptors that will close the gate from the bottom up. All right. Acute pain. Pain is less than 6 months duration, and you can identify what caused it. It's mediated through rapidly conducting pathways, and that acute pain is associated with any kind of an increased tone, increased heart rate, increased blood pressure. It's well localized. It's more diffuse with muscle pain because that's just the nature of pain, but it's well localized. So if you're kicked in the shin and the shin hurts, it's an acute pain problem. Okay? It lasts as long as that noxious stimuli is present. And it's protective because it limits function. You sprain an ankle, you want to limit your function because every time you move your ankle in a certain way, it's going to cause pain. So what do we do for this patient? We need to decrease that inflammation. We need to modify that transmission of pain somehow. So maybe through electric stim, maybe through ice, maybe through a portable TENS unit. And we need to find out what that underlying disorder is and get rid of it. Chronic pain can be classified according to the pathophysiology. So it can be nociceptive. So those stimulation of pain receptors, again, by that noxious stimuli. So we have ongoing tissue damage that was initially associated with an acute injury. Neuropathic pain, it can be burning, lancinating, which is really painful pain, sharp, stabbing, paresthesias. It's the result of that peripheral or central nervous system dysfunction. Chronic pain doesn't resolve in the expected time frame. Chronic pain, usually you're saying that pain is going to resolve within 6 months. Chronic pain may just go on and on and on. A patient can complain of chronic pain for years, and this patient may have to be referred to a pain clinic. It can start as acute. It goes beyond that initial attack. It's very difficult to manage. And 1/3 of the people in the United States have chronic pain, and you could see it in their faces. 14% of these are musculoskeletal. Okay, caused by mechanical, thermal, or chemical stimuli, as we said before. So types of chronic pain: arthritis, ischemia, cancer, are all associated with this chronic nociceptive pain. And they can also be results of the change in the sympathetic nervous system as well as the adrenal activity. You can get a decrease of these endogenous opiates or a sensitization of their primary afferent and spinal cord neurons. So some patients have an increase in nociceptive input and a decrease in enkephalins. This just happened. They have an increased sensitivity to both noxious and innocuous stimuli. So these individuals have hyperalgesia, which means that the pain is greater than you would expect. I mean, it's just touching them causes them to have pain. And they could also have allodynia, and allodynia is associated with non-noxious stimuli becoming painful. So they have pain, but it's super, super sensitive. They have pain. And even if you just touch them or move them, they complain of pain, even though it's non-noxious stimulation. And central sensitization is an increase in the magnitude and the duration of the pain response. You have an increased receptor field. The pain is increased in the brain, and it lowers the threshold for what actually causes pain. So the pathways will transmit pain, and they continue to discharge after the pain is removed. That happens with centralization in the brain. The types of pain. Again, I just put it in a graph for you. Acute pain is pain that lasts during the time of healing. Chronic is beyond the time of healing, and referred experience pain in one area and that's really coming from another. With acute pain, you have a known etiology. With chronic pain, it's abnormal. In referred pain, you can refer to other parts of the body. Acute pain is well localized, defined. Chronic pain will continue after the noxious stimuli ceases. Then referred pain can refer from a peripheral nerve to a distal innervation. So if something, remember we gave the example of supraspinatus? Supraspinatus innervated by what? Suprascapular nerve, what nerve roots? Anybody remember? C5 and 6, right? And where's C5 and 6 dermatome and myotome? Down the lateral part of the forearm. Remember we said supraspinatus can mimic a lateral epicondylitis, referred pain. And then finally, pain will last for acute pain as long as the noxious stimuli persist. Chronic pain is associated with physical, psychological, social dysfunction. And referred pain can refer also to any kind of an organ, internally or outside tissues, muscles. There's a group of things that are all grouped together. I'm sure you've heard of reflex sympathetic dystrophy. I'm not sure if you have or not, but they're exaggerated symptoms. They're grouped together now into something known as complex regional pain syndrome. And complex regional pain syndrome is caused by an overactivation of the sympathetic nerve system. They're abnormal sympathetic responses. So you get exaggerated responses. There's something known as causalgia, reflex sympathetic dystrophy, RSD. No one knows why these things happen. They're not well understood. Etiology is unknown. You could have something called shoulder hand syndrome, post-traumatic dystrophy, Sudex dystrophy, where you have warm, dry skin, then it becomes cold, moist, and sympathetically maintained pain. Signs and symptoms associated with this can be hyperhidrosis, so excessive sweating, edema, stiffness, decreased hair growth, trophic changes, redness, heat, anything. These people have, again, they have hyper allodynia and they're hyper, what's the word I'm looking for? Everything's noxious to them. I had several patients that had RSD. Usually RSD patients are treated with a group of people, not only physical therapists, but they're treated with psychotherapists, they're treated with pain management clinicians. Some of these people have morphine pumps. Some of these people have surgery to cordotomies to cut into the cord to prevent the stimulation of pain or the transmission of pain to the brain. It's really, really horrible. And as I said, some people don't believe them that they really have pain, but they truly have pain. It's just overactivation. I had a patient one time, she was 40 years old, and she was playing soccer with her son, and her son kicked her in the shin. She had pain. And 6 months later, she had come to the pain clinic, and she was not ambulatory. She couldn't walk. There was no fracture. There was no break. There was nothing. She had reflex sympathetic dystrophy. And we had to treat symptoms because that's all you treat. And plus the symptoms of pain, they gave her a morphine pump. And she was able to use that and exercise and get to better, and she was walking. But again, this is a terrible thing and they don't know what causes it. It's just an overactivation of the sympathetic nervous system. So they can do that surgical procedure, or they can block the transmission from the peripheral nervous system to the brain by doing something known as a cordotomy. They can do a synovectomy, removal of the synovial membranes, and they can accompany that with an arthrodesis. And what's an arthrodesis? Anybody? Anybody remember from last semester what arthrodesis means? Surgical fusion of the joint. Okay, not an ankylosis, but it's arthrodesis, surgical fusion of the joint. So they could do that with somebody who maybe has such chronic RA, all the bones have moved, everything's so painful that they actually fuse it. And they could also fuse the spine itself. So they could do a spinal fusion. So types of pain behaviors. A patient, if you, as I said before, when you just look at a patient, you could see that the amount of distress the patient has. So they could have an audible expression of distress. You could hear it, or you could see it. They walk. Antalgic gait. We use the word antalgic. Antalgic means painful. So they have distorted ambulation or posture too. The way they hold themselves, they don't stand up straight. They have a very negative affect. What does that mean? What does that mean? Are they going to smile when you look at them? Are they going to, when you walk into the room, say, "Hey, Casey, how are you?" Is he going to say, "Oh, I feel great today"? He's probably going to say, pain, I have pain, or "I'm all right," or "How do you think I am?" or any of those types of things. They're also going to want to avoid any kind of activity because they're afraid that anything they do is going to cause them to have pain. Feelings associated, oh, come on. The feelings associated with pain. Cutaneous pain, well localized, sharp, prickling, tingling. Musculoskeletal pain is poorly localized. So if somebody has musculoskeletal pain, they said, "Oh, it feels dull, it feels heavy, it aches, cramping." Visceral pain refers superficially and it has an aching quality. So here's a pain description and related structures. A muscle is usually cramping, dull, achy. Nerve root, sharp, shooting. A nerve, sharp, bright, lightning-like. I said before, lancinating. Sympathetic nerve, burning, pressure-like, stinging, aching. Bone, deep, nagging, dull. A fracture, sharp, severe, intolerable. Then vasculature is throbbing or diffuse. So these are all types of pain descriptions and how they refer. Anybody know what VAS means when you measure a pain? VAS, a visual analog scale. So we have visual analog scales that we can use. We have numeric scales. We have face scales for children, because if you ask a patient or a child on a scale of 1 to 10, 10 being the worst pain they ever had in their life, can they answer that question? No. So can they point? How do you feel today? Sure, they can point. They can also be used, face scales can also be used for somebody who has cognitive deficiencies or somebody who has dementia. And then semantic differential scales. There's a McGill pain questionnaire. So a patient will question, a patient will circle a questionnaire regarding to what type of pain they have. And we have some examples here. So visual analog scale. There's different types of visual analog scales. If we look at this scale, we look at the scale, we have no pain to the worst pain possible. We have a 0 to 10 pain possible. And then we have a visual analog scale that says no pain and worst pain possible. If we give this scale to a patient, which one do you think might be most accurate for us?
Probably the visual analog scale.
Which one of these? The one that says no pain to worst pain, the one that says 0 to 10, or this one?
Probably the first one.
Probably the first one. Anybody else?
Maybe the graphic scale.
1 through 10.
I would say the functional.
Okay. This pain scale is given out a lot, and this one in particular is given out with the Womack pain scale for arthritis. And this is probably the best. You know why? Because if you give a patient a scale like this or like this, somebody might say, "Oh, it's a 5 today. Oh, it's a 4 today. I don't know. Maybe I said 4 yesterday. Maybe I'll say 7 today." The patient has no idea where they're marking. This is a 10 centimeter scale, and it's you would have to then take out a ruler and you would have to look at where they have pain. You know, the other good thing this is for is if somebody is a malingerer. Remember we talked about a malingerer or a symptom magnifier? If somebody is coming from a facility and maybe they're saying they have more pain than they do, you know, those kind of people will always mark worst possible pain, worst possible pain, worst possible pain. But they may sometimes say, you know what, I better say something else today. I'll go midway. But they don't remember where they've done this or this or this. So this tends to be at times a little bit more accurate. Okay. So there's a word descriptor scale, 0 to 5, 0 to 10, 10 being the worst pain you ever had in your life. And then there's these graphic scales and functional pain scales. No pain, tolerable pain, prevent any activities, etc. There's all different kinds of scales. This Melzack or McGillen-Melzack questionnaire, remember Melzack and Wool are the people that in 1965 talked about pain and the gate theory of pain, because that's what is known as the gate theory of pain. If you got a patient, and these are related to specific things, so someone that would look at this pain scale or this pain questionnaire, it would be important for us, but it would also be important for people in pain clinics, because we would have to then determine, gee, is there any kind of psychosocial component going on with these people? Do we need to refer these people to a group of people who can treat them? Because if somebody who's going to circle every one of these things, they're really going to be in trouble. Okay. So pharmacological approaches to pain. NSAIDs. NSAIDs are non-steroidal anti-inflammatory drugs. And what they do is they inhibit pain and inflammation. The problem with NSAIDs, and we know what an NSAID is, right? An Advil, Aleve, aspirin, they're all types of NSAIDs. They will inhibit pain and inflammation, but taken over time, they can provide bleeding, or they can cause GI irritation as well as bleeding in the gut, so stomach. So a person that has is on NSAIDs 4 times a day for a long period of time can complain that they have problems in their stomach and eventually get an ulcer. Okay. Acetaminophen will inhibit pain. And anybody know what a type of acetaminophen is?
Tylenol.
Right. But it could also, the downside with Tylenol, it has skin rashes and liver damage if you take it for a long period of time. So what do you have to do with these people that are on acetaminophen? What do you think? Should do blood work. You should do blood work to look at the liver enzymes. Okay? So when people tell you, gee, my stomach feels bad, or, you know, I really feel funny and my belly hurts, or et cetera, and they're not NSAID, you want to think, oh, you know, hope ulcers not forming in this patient. Acetaminophen, their liver, you need to do liver enzymes to make sure that they're not damaging the liver. You also need with Tylenol, things like that too, and to flush it out a lot. So you need to drink a lot of water. And finally, opioids may mimic endogenous opiates. As we said before, our endogenous opiates are our enkephalins and our endorphins, and they can block C fiber input. So things like morphine, hydrocodone, oxycodone, codeine, methadone, and patient-controlled PCA, patient-controlled, what is this? I'm having a brain fart here. Come on, we just did this the other day. Anesthesia, PCA, patient control anesthesia. Okay, so this type, what is the problem with these opioids? What's the problem with these?
They're addicting.
Yeah, besides the fact that they make you drowsy. So if you want to take an opioid at some points, usually you refer these for a patient at night so they can get some sleep. but they also are addictive. So these are some pharmacological approaches, as well as antidepressants. And these are used more for chronic pain, okay, tricyclics, like Elevil, and they're thought to improve your mood, and they're also thought to exert an anti-nociceptive effect, as well as local injections. What's the problem with corticosteroids? Oh, it says right here. Repeated corticosteroids can lead to tissue breakdown and deterioration of tendons. Okay, so you don't want to repeat corticosteroid injections for a long period of time. You get several, but it can cause tissue breakdown. Opiates, local anesthetic. So they can relieve inflammation. What about topical analgesics? Yeah, topical analgesics also work like capsaicin. They'll deplete substance P. So any kind of a topical analgesic will work as well as a local injection to relieve pain.
Professor?
Yes.
Is the corticosteroid, does that cause tissue breakdown because it numbs the musculature around it? So you're moving it, breaking it down, or does the actual steroid cause the muscle breakdown?
The actual steroid causes the breakdown. The actual steroid causes the breakdown. So when you go to a physician, they don't like to give you a lot of corticosteroid injections, but they will if there's, if it's really acutely inflamed and they need to calm that down. They'll give a corticosteroid injection. Is Professor Maley still there? Or did he leave?
No, he's not here.
He left because I was going to say he had a shoulder problem and he had initial injections of corticosteroids, but you can only give them for a few times because you don't want that tissue to start breaking down, and that tendon will because of the steroid itself. Okay, so basically this is it on pain, and we will be talking about heat and we'll be talking about electrical stimulation. But the important thing to take away from this is the fact that there are several types of pain and how the pain is transmitted. And I also want you to know that the difference between acute and chronic pain and the sensory afferents that are associated with the nociceptor inputs and the sensory afferents that bring pain, the information regarding pain to the spinal cord itself. And the tract that's responsible for providing or for transmitting pain to the brain is the spinothalamic tract. Okay, so remember that. That brings information to the thalamus regarding pain and temperature changes. Okay. All right. There is a, I don't know if I should, maybe I should just give it to you. Oh no, do I have it here? Can I share it with you? Let me share with you. Close this down. All right. Get out of here. And you can't see anything now, right?
No.
No. Okay. All right. You'll be going into lab. Let's see if I can see. And you'll be doing I don't know for sure if I could send this to you. You know what? I'll just send it to you. Send. Let me see. Okay. I'm opening it up. Now I'm going to share my screen. Okay, can you see that? Can you guys see this?
Yeah.
All right, this is what I'll be sending you because this is what you'll be doing in lab today. So I'll just send it to you right after this class. But you guys are going to figure out whether this is respiratory and metabolic acidosis, alkalosis, and then you'll be doing all the rest of these things in lab. Okay, getting you ready for next Wednesday. And then we're also going to figure out how it is we want to do a practical. And it may be something quick because there's really, I just want to make sure that you guys know how to do stump wrapping and understand sterile techniques. And have you all been on the tilt table?
Yes.
Okay. So I want to make sure that you're all comfortable with what's on the tilt table and how to perform blood pressure also when someone is doing an activity, such as, I know some of you did it last time with running on the treadmill and taking the blood pressure at the same time. I want you guys to try to get used to listening to the BP while somebody's actively moving. You know, whether it's on the UBE or whether it's somebody running. UBE is going to be a little bit harder to do, but running will be much easier to do because you'll be able to access the arm. Okay, so make sure you all do that today. I'm going to be popping in anyway. And Monday, as I said, we're off. Friday, you'll be involved in, I only heard from one person regarding not being able to attend, but everybody should be attending on Friday. Okay? And I will send this right after class.
Thank you so much.
Yeah.
All right. All right. Have a good day. Bye.